Thank you to those who are putting names in. We're really happy to have you all here today. So welcome to our introductory webinar on the ISARIC Clinical Epidemiology Platform. I'm going to start slowly so that we can allow people who are just a minute late to join and attend. But just as housekeeping points, we'd really like to hear from you. We'd like to know who you are, and we welcome you to exchange on the chat function of this call. So please put in names, affiliations, anything you want to say to each other. You are really welcome to do that. There's also a question and answer function. So anything that you want us to see during the course of this webinar, please use the question and answer function for that one. We'd be thrilled to have your questions. The structure of the webinar is that Esteban and myself will present during maybe the first 30 minutes. And then if you need to go, that's great. But if you'd like to stay, we're happy to stay on for up to the full hour to take questions, comments, listen to your experience. So please, again, say hello to each other within the chat, but use the question and answer function to pose questions for us. And we'll see later if any of you want to contribute during the question and answer session in the second half hour of this webinar, then we'd be pleased to hear from you. So a welcome to everybody. My name is Laura Merson. I'm the head of data at the Pandemic Sciences Institute at the University of Oxford. Our group is called ISARIC. We know several of the people on the call and the institutions, but there's a lot of new names and institutions. So we're thrilled to have this group participating. Thank you very much for being here. This is the first in a series of webinars. We have spent the last 15 years really gaining experience in clinical epidemiology data collection and analysis. And as a result of that experience, we've built tools and systems that we want to start sharing with you from today. So today is a quick intro to some of the tools, and we'll follow this with a series of webinars. Please make sure that we've got your email address so that we can ensure that you're invited to future discussions. If you think we might not have it, please feel free to put it in the chat and we'll be sure to record it. So without further ado, I'll move on to a brief introduction of ISARIC for those who don't know us so well. ISARIC is a federation of investigators who, for more than a decade, have really championed the development of a coordinated, agile approach to clinical research on emerging infectious diseases. And ISARIC's creation was a response to the lack of actionable research evidence generated during the 2009 H1N1 pandemic. And it was this collective failure of the global research community that really forced the recognition that we were ill-equipped to deliver research that was needed to respond to outbreaks real time. So from this grassroots initiative emerged ISARIC to tackle the challenges of improving patient outcomes during outbreaks. And the strategy to do this includes the development of pre-approved standardized protocols and data tools to support the integration of research into a public health response. So I'll share just a quick introduction to some of the activities that we've done. I hope you'll take a look at our website if you're less familiar with us. But you can see that, for example, we've recently delivered the DENCORE study, which developed the first global core outcome set to improve dengue clinical trials. And we've also done research to inform the development of new recommendations on the treatment of severe yellow fever that was led by a team in Colombia. We recently launched the Scientific Leadership Program that gives mid-career researchers from low and middle income countries the skills to benefit, to become independent research leaders. And we've published the Rapid Stigma Scale that measures stigma during infectious disease outbreaks. We've also published the results of IMISOI, which was the world's first clinical trial on bubonic plague that tested the differences between two different treatments to get a more effective treatment for bubonic plague. Now, this webinar is really about the data tools that we've developed, which is one aspect of of the activities that ISARIC does. But I want to share with you from a personal experience why it is that these tools are so important and how it is that ISARIC can play a role in emerging infectious disease response. And I will give you this perspective from Senegal, which is where I am based. So in addition to my role at ISARIC, I serve as the head of clinical research for the Institut Pasteur de Dakar. And you may know that right now, Senegal is having a major outbreak of Rift Valley fever. So as of yesterday, there were 295 cases of Rift Valley fever, mostly in north of Senegal, but has now spread to 19 of our 46 regions. So we're very concerned about where this epidemic might be going. We've had 25 deaths, sadly, to date. And we need to respond. This is one of the biggest outbreaks of this type that we have ever had. And there are major knowledge gaps about clinical management, immunological response, viral dynamics, and really just the characteristics of this disease that we need to know so that we can develop effective countermeasures. So what we need to deliver this, of course, is a rapid research response that can inform patient care, guide our Ministry of Health's public health response, and also support the development of vaccines, therapeutics, and diagnostics so that we can avoid these sorts of outbreaks in the future. But as many of you know, that delivering research, even in the context of an outbreak, requires substantial groundwork. So you need to get all of your documents together, you need to write a protocol, ethics forms, study tracking forms. I need the ethics approval as well as institutional approvals. I need to identify the researchers who can deliver this and make sure that they're properly trained. Of course, have patient advocacy initiatives, get all of my labs and sampling flow set up, have all of my study flow checklists. There's so much to do when you need to deliver research. And just taking data as one example of the different areas that need to be developed. So we need to develop a case report form. We need to build a database. We need to create a quality assurance workflow. We need to have a statistical analysis plan. We need to write an analysis code. And we need to be really rapidly generating outputs that clinicians and policymakers can act on now. As well, we need a mechanism to share these data and hopefully collaborate with other researchers across the country or in Mauritania, where the outbreak is also prevalent, or across Africa, where there's other outbreaks of Rift Valley fever, so we can all learn from each other. But how do you do this in the context of an outbreak? And also, in addition to sort of these immediate needs, we need to make sure that the way in which we do data management optimizes the relevance, quality, and impact of the data that we collect. And to do that, we need to do things like use evidence-based templates for the case report forms that we are using for our patients. We need to make sure that we integrate data standards and controlled vocabularies so that our data are interoperable with past outbreaks and with other people working on outbreaks. In Senegal, we operate in French. And so to build databases in French will create barriers with our colleagues in Kenya, for example, or perhaps even Mauritania. And so if we use interoperable standards, that will overcome those barriers. We need to make sure that our analysis code is robust, that it's reusable, and also that it's openly available. And we need to make sure that our data are fair. So findable, accessible, interoperable, reusable, all of those aspects that make sure that you have very strong data that can optimize the impact of the data that you collect and the evidence that it generates. So there's layers of challenges in being able to develop and deploy actionable data and evidence in the context of an outbreak. And it's exactly this problem that ISARIC is framed to respond to. And just as one example of a case in which ISARIC did this was during the COVID-19 pandemic. So in the COVID-19 pandemic, ISARIC launched a global data platform that had standardized case report forms and was open to everyone to be able to use based on standardized vocabularies and robust data standards with analytic pipelines that could quickly generate reports and use the data that people were collecting. And so what this enabled was the development of a huge database of more than 1 million patient records from hospitalized COVID-19 patients across 83 countries. We were able to integrate the data rapidly and generate reports that compared what was happening across different countries. This has resulted in more than 130 manuscripts. We had 19 clinical data reports that were being published weekly at the start of the outbreak. And additionally, 4 dashboards that could feed evidence into policymakers, either nationally or locally, or to clinicians who really wanted to understand what was happening in their context. And so from that experience, we as ISARIC learned a few lessons about how to do data management robustly and at a global scale in the context of an outbreak. And that was first and foremost, we need to make sure that things are standardized. We need consistent questions and definitions so that people are defining things in the same way so they become comparable between contexts and between outbreaks. But we also need to stay flexible. So we need to have case report forms that are ready for people to use based on the evidence base and the research questions that are most important in that outbreak. But we also need to be able to adapt those really quickly and easily for sites that have very low resource, perhaps, or low ability to collect a lot of data, or the sites that have perhaps very intense patients that need a lot of care and have the time to be able to collect those data and be able to fit all the cases in between. We also learned the importance of decentralization and making sure that we could support local data management and the capacity to manage data nationally, locally, regionally, or in any way that any country or researcher wants to manage, while still maintaining the ability to have it globally integrated. With 1 million patients, we quickly learned lessons about scalability and our need to be able to handle large multi-site, multi-regional data sets, and the absolute importance in the context of an outbreak to be able to get answers back fast. So we want clinicians to be able to put in data that can then be rapidly analyzed and returned to them with answers that are relevant to the patients in front of them. And then lastly, the value of collaboration, both in building a robust evidence base and also in supporting the great breadth of research that's going on across the world and making sure that we build systems that recognize the contributions of all of those different people. So these were our key lessons and takeaways as ISARIC from the COVID-19 outbreak. And as a result of that, we've developed a suite of resources, tools that we call the ISARIC Clinical Epidemiology Platform. And it's that platform that I'll hand over now to Esteban to present.
Thank you. So I will show the main aspects of the platform and how we use technological and computational tools to help in the evidence generation that Laura mentioned. So the natural habitat for our tools is GitHub because all our tools are open and they are available for people in our ISARIC research repository. We will share the link later. But to explain how we envision this ISARIC clinical epidemiology, we have this diagram. When we acknowledge that there are several people involved in clinical research that have different roles in responding to outbreaks and in generated clinical evidence. So that when an outbreak happens anywhere in the world, we think that a protocol should be in place, that is CCP. We can share more materials about this and have other webinars discussing this, but that protocol is developed by clinical researchers and healthcare and epidemiology professionals that make that ready in place in their particular sites and settings. When a particular outbreak happens, the first tool that we share or that needs to be developed is the case report form for that particular outbreak, and that needs to be developed by clinical researchers and also healthcare and epidemiology professionals. And we have a tool that we call ARC that is a library of the best version of all the questions that have been asked in CRF in the past 15 years that that ISARIC has been responded to outbreaks. That library of questions needs to be standardized but flexible and so on. After that, the data needs to be captured, and in that moment, the data manager also needs to create a database in a data capture system so people in the front line can capture the data in a secure way. For that, we use RedCap, but we have Bridge that is a web application that will be the interface between our library of questions and the data capture system. And I will show how that works in a moment. But after that, that data needs to be analyzed in an efficient way. So we have another set tool that we call Vertex, and the purpose of that tool is that being used by data analysts, but informed by also clinical researchers, uh, data managers, and the healthcare and epidemiology professionals to generate evidence that could be used for both improve the care of the patient, but also to guide the public response. So with this, our first tool will be ARC, and ARC is essentially a library of the questions that we have. This is where it lives. This doesn't look so nice, but I will explain really quickly what are the main components of ARC. Essentially, is a machine-readable library of questions when we have standardized way of asking each of the possible questions that we have used. Here we have an example of how an element of ARC looks. We have the presentation, we have sections, we have how that variable is called, what is the type, what is the human readable label, what are the actual answer options, the definition, the completion guide, the SNOMED code, and so on. So this ensures that ARC, in addition to be a library of questions, is also a tool that will allow us to harmonize clinical data collection and to use standard vocabularies and to adapt to different research contexts. The other important element of ARC is the list. So we have several lists with conditions, drugs, and a lot of options that will change depending on the particular context. So for example, for a particular disease, certain drugs are applicable and others are not. For a particular site, a particular antibiotic can be available or not, and we handle that through lists, and that will be clear when I show Bridge how we actually manage this, but that's the purpose of the list. And the third main component of ARC is what we call the data capture schema, and this is because the ISARIC Clinical Epidemiology Platform is designed to support the response to outbreaks of emerging infectious diseases. So for that, this is how we think that the data that is collected looks. So during the path from a patient over the observation period, there is a illness onset, then there is a space of time when the patient starts to develop, for example, symptoms. Then we have a presentation that is when the patient seeks for or have a contact with a clinical institution, sorry. Then we have a daily observation period when multiple things are measured, then there is the outcome, and then the follow-up, and then finally the end of the study. So we decide to divide in these particular blocks, thinking that some of these, and those will be the dark blue ones, are meant to be captured once. Even the onset to care that can happen on several dates is captured at presentation. So these things are captured once, but then we have several forms or events that can happen multiple times, and we don't actually know how many times it's going to be happen in any particular outbreak. So things like daily and follow-ups can happen once per day, for example, but we have other elements like drugs or pathogen testings that can happen multiple times per patient, and there are different times that happen for each patient. So this is the clinical characterization data schema that guide how we use a ARC and Bridge. So because ARC is a machine-readable library of questions, it's not intended to be used by humans. Because of that, we also develop Bridge, that is a machine-readable, a web application that is meant to operationalize ARC. So you can, this is open, it's in bridge.isari.org. You will go there you will find this page. In here you will find a brief description on how it works, our funders and partners and other tools that we have. Importantly, we can have access to a guide of how this is intended to be used. And here you can access some documentation that is meant to help with the use of Bridge. But in reality, it's very simple. When you click create a CRF, this is where you are going to be. And we have three main sections here. A bar for settings, our main tree, and the illustration of how the CRF is going to look. We can also access settings when we can select the ARC version because ARC is iterative, and it's iterative because we are adding questions all the time. We are refining the ways that we are asking questions, and we are improving that in general, and also support the translation of those CRF to some languages. We will present this in a future webinar. And the other important thing is the output files that people can select to show. And we have an XML with the clinical characterization data capture schema that I just present. We have the REDCap data dictionary that is the main output, and the paper like CRF and completion guide. People can select to download what they need for that particular moment in settings. And then we have templates. I will talk about those one later. The next thing is the actual tree. In here, we will have ARC, the ARC version here, the different forms that compose that. Those are linked directly to the data characterization schema. And inside of this one, we will have the different sections. And inside that section, we will have the different questions. So all the questions are lowercase, the sections and groupings are in uppercase. So in here, when an outbreak happens, people can come and start selecting the variables that they want to include in that particular CRF. And they can do this by just clicking what that is. If they do have doubt about what this is referring, they can click and it will have the definition, the options, and the completion guide. Importantly, there are some options that are user-less, so people can actually go and modify these answers. So for example, here we can select the actual countries that we want to include in a particular study. And that all helps the customization. We have something similar, for example, for units. So some of our variables will support that things are as in a particular unit, like Celsius for temperature, or if we have sites that will collect sometimes multiple sites that sometimes collect in Celsius and others in Fahrenheit, you can select both. And Bridge will handle all those decisions in the back end and will create the appropriate questions to do that. This basic functionality is one way of using. You can come and see all the sections and decide what actually is relevant for your particular outbreak. Importantly, there are thousands of questions here, so this is a way of using. We do support another way of using that is based on templates. So for example, we can go here and templates, and we have what we call archetype disease CRF or archetype syndromic CRF. So these are CRF that were developed under a expert collaborative process when a lot of expert gives input on the CRF for a particular disease and objective, and these are listed here either as diseases or as syndromes. We have more under development, and we will present how we actually develop this in a future webinar. But right now, people can come to this and they can select that CRF that they are interested in. This will take a minute to populate, but all the questions that were selected by this group of experts for that particular disease are going to be checked. And in here, people can actually come and customize this for their particular needs. For example, based on what Laura mentioned, people can come here and say that they don't actually need the, the treatments or the respiratory support or the advanced ICU care. So every time you deselect those groups of questions, those are going to disappear from the actual CRF. And after this is done, it's possible to just to create put a name and generate. This will generate the files that I mentioned at the beginning. Those files are first the paper-like CRF. So that one is going to look like this. This is intended to be printed by people and will have the CRF in a way that people can fill this on paper after printing. So this has been formatted in a way that don't have occupied a lot of space, that is clear what questions are related one and other, and so on. Additionally to that, we can have the completion guide. So this is a document where people can find all of the questions, how they are meant to be completed, what are the things that are needed to be done, and this is easily, you can search in these particular things by the sections and click, and that will take you to the pertinent section in there. That will be the additional file that is downloaded. In addition to that, it will download a XML, that is the clinical characterization XML, and a CSV, and those are intended to be used in REDCap. So when people download those, their data managers can go to their REDCap when they have access. They can quickly create a project just uploading that particular XML that was generated from Bridge. That will create a data capture schema that is this one that we see here when we have an initial assessment with presentation on day one. We have further dailies that are a repeatable form, so this can be included as many as people need. Then we have the summary for medication and pathogen testing, where we have these possible groups, and then we have the outcome that will have the outcome for under withdrawal and the possibility for follow-up. So this is how in REDCap that data characterization, that clinical characterization data capture schema is represented. But further, people can come here and select the CSV, the data dictionary that was developed or was generated by Bridge. They can upload that file, and that will transform that into a shorter version, because for that particular CRF, we don't use all the forms. But after that step, people can come here and start collecting data for patients. And you can see that in here, this is actual data capture, and it will handle, for example, the formatting of how this looks in REDCap, but in addition to that, will handle the, for example, the branching logic. So if we select a particular question, that will ask the additional questions that are only for the ones that you ask yes or not, and so on. So after this, there is obviously a data management process of give people access and to actually collect the data. But with this, data is in a format that is clear, that is understandable, that is intended to be useful, and we can connect with this, with that format automatically. So our third tool is Vertex. Vertex is you can access here in ISARIC Research.vertex. People can come here and clone or download that piece of code. This is a Python application that looks like this, but your like biostatisticians and data analysts can come here, download the actual code. This is how it looks. And if they run that code and modify the API and link that to an API that can be created in REDCap, that means that that application will launch responses like this. And it will handle visualization by also analysis of the data. So all of these plots and the analysis required for example, this plot, or for example, this table, when we can either present the description, do comparison between groups, present, for example, a frequency that was a frequency of treatments in this kind of plot. All of that is code and presented in Vertex, so it's transparent, it's open access, and people can input on that. And we go as far as having some what we call essential medical statistic models. So we are seeing here for the synthetic data how the risk factors look, and we will present that with plots. So we call these reusable analytical pipelines. Those reusable analytical pipelines are intended to have best practice into them, so people can use those to develop their own statistical analysis plan, but the code is transparent and is there. So this is the final tool when the evidence is shown to people. This is how I run it from my local desktop, but if you want to see how it looks and play around with Vertex, you can go to demo.vertex.isaric.app, and in here you will see some of our projects, and you can change between those, and you will see the same type of plots that I just showed you, and so on. So that is how we think outbreak research can be streamlined, considering that data capture and analysis can be like put together to design a quick responses. I will end there because I am close to a little bit over time, but we are happy to take questions and discuss further.
Thank you very much, Esteban, for presenting those. So if we'll recall, I needed a case report form, a database, a data quality pipeline. I needed a statistical analysis plan, some analysis code, and something that my clinicians can get feedback on immediately. And you seem to have solved all of those problems for me. You've got standardized templates of case report forms that I can use and adapt for my context, and then automate the generation of a completion guide that tells everyone how to fill them out, and also the database needed to collect the data. So I got to skip 10 steps in that process. The first thing I did when we had an outbreak, I called ISARIC. They were maybe easier for me to get than you, but they're as open to helping everyone as they were to me, honestly. This is the first time I got to use them myself. And so I had a case report form in record time, had a database set up that I could immediately get the clinicians on the ward to start testing and see if it worked well. Now, if only ISARIC could solve my issues about getting ethics approvals really quickly, then I would be ready to go and we'd be filling up that database. But I'm sure as soon as that comes through, then the team will be ready with the analytics to support us. So it was really an interesting experience for me to be on the other end of these tools and to see how they can really work in practice. And I hope that all of you for whom this is applicable, that you'll do the same. First of all, just an explanation, my chat is about 10 minutes delayed, so forgive me, I can't see everything that's going on in the chat, such as the conditions in Senegal today. So what I'm going to do is open up our question session, either by using the question function that maybe Sarah or Tom will let me know if there's something there, or just by inviting anyone to raise their hands. We would love to hear from you. We would love questions. We'd love your feedback if you've tried things. Also, if you need to go, we completely understand if you want to drop off, but we're happy to stay around. We'd really love your participation and to get your feedback. And just before you do, I want to just reiterate that this is first in a series of webinars. We're planning to do about one a month. And the next one will be some of our users like me who have used the platform in their context. So researchers from Colombia who used it in the context of a yellow fever outbreak, researchers from Rwanda and DRC who used it for an Mpox outbreak, and researchers based in India, but a collaboration that's across Asia and Latin America, many of whom are on this call, who have used it in the context of dengue outbreaks. So those will be presented at our next webinar so you can see how it works in practice and talk to the people who use it and understand the challenges. And after that one, we'll launch into some more technical presentations. How do these things really work? What's the back end? Speaking especially to the data managers, the statisticians, the more technical folks on your team to make sure that they can use the breadth of the tools really well. There's so much there that we haven't got time to tell you all about today. But for example, from Senegal, this case report that I generated it in French in a completely compatible version with the English or the Spanish or the other available languages. So there's layers and layers of other tools that are available that we'll tell you about as we go. If you can't wait to hear from us, then don't worry. You can go to the GitHub and you can download the programs. Everything is openly accessible, openly available, shared, and we're really happy to support setup. So with that said, please make sure we've got your email address so we can invite you to future calls. And we open the question answer session for anyone who wants to contribute. Please feel free to raise hands or just unmute or put questions in question and answer, and then somebody will help us manage to see them.
I see in the chat a question from Alan Jonas about if there is any data sharing embedded in the ISARIC tool. And maybe to break the ice and start asking, like we can start with that one. Essentially, yes, there is, and we plan also to have a separate webinar about the partner analysis schema, how that works. Importantly, all that you saw is open access and is intended to be used by each site. And we are happy to help in setup. We are happy to help into how to streamline that process. But this will continue to be your project, your data, and there is no need to, or not requirement of further collaboration if there is not that possibility. We also support the partner analysis schema that essentially is intended to support collaboration between different institutions to create a stronger evidence. That will be presented later, but that is how we were able to, for example, generate those 130 papers that Laura mentioned that were very impactful during COVID and so on. So the answer will be yes, we can share more details later, and or if someone is can write us a mail and we can answer that back.
Simon, do you mind if I pick that one up? Because that's one question I can find now on my phone about the data sharing that we've embedded. So very much so, the COVID-19 platform, I think, was our exemplar of that. And we really support data sharing in two ways. One is that we make sure that your data are in a format that makes it really easy for you to share. You share with whoever you want, you initiate those collaborations, and you take all of those decisions. The other is we offer a data sharing platform where all of these data that are interoperable are put together, and people who contribute data can then request access to the collection of data and can execute that analysis that they propose in collaboration with all of the people whose data they're going to use. So if you put data into the platform, in order for someone to use it, you will get a copy of the statistical analysis plan that you're welcome to feedback on. And you'll make sure that you see that paper before it goes out, as well as being cited on that paper as a collaborator. And so we've really driven a lot of collaborative publications that way. Thank you for the question. And Shrub, I can see a raised hand, please. Hopefully you can unmute and ask your question. Shorb and Lisa, are you able to tell us what your question is? Mhm. Okay, we're going to give you a moment to see if you can get that mute button off. And it probably is on our side that we need to help as well. So we'll see if we can get that working. If all else fails, we welcome you to put that question into the chat. I'd love somebody else to then ask a question so we can try to figure out our microphone use. Sure, I think if you push your mute button, it should be able to turn you on and let your microphone work. Anyone else want to try? Ask the question so then we can help to figure out our sound. Yeah, okay. Maybe I'll take one other question from the chat in the meantime, and that's whether we should have separate case report forms. In this case, it's about dengue fever for adults and children. If I may just say, it's from Dr. Ian from Okru in Ho Chi Minh City, and I'm very happy to see your name, Dr. Ian. So I'd like to tell you briefly about an initiative that we're working on with the pediatric network called PENTA. And PENTA is helping us to develop pediatric specific variables for all diseases. The first projects they're starting on are mpox and respiratory diseases, but the idea is that pediatric variables apply to all diseases, just some are more applicable to certain diseases than others. So my answer to that, Dr. Ian, would be yes, we should have different variables available to complete for children versus adults. And that's something that we are very focused on. And I hope that our mpox pediatric case report form will be the first to come out before the end of the year, followed, thanks to PENTA, by the respiratory case report form after that. And then based on that experience of a couple of diseases, we'll be able to build a collection of variables for pediatrics and for pregnant women that are available for you to use on any case report form. So that's a new development that we're working on. And Shoaib, I'm sorry to say that we didn't get you to speak to us, but if anyone else wants to try, we'd be really happy to have verbal input. Esteban, did you want to take the question about establishing a database in the ICU?
Yes, definitely. So thank you for that question. I feel like it's very pertinent. So the question is in the chat, but is if these tools can be useful in establishing a general database, for instance, in the ICU in general, and the person asking this is also. So the answer is yes, even, so the answer is yes. Like, definitely, it can be from the context of each site will have a harmonized database. If they have access, for example, to RedCap, they can create their own one in there, or that could be if there is a central place when that lives and a data management team that give access to those people submitting data, that would be the other way. In fact, we have been discussing with in Canada with CCCTG the possibility to include some of the CRF that they develop for both pediatric and adults within the ICUs, to include it in our systems, or that are supported with the infrastructure, the technological infrastructure that we have, and those can be shared in that way. So, don't know if that answer is clear. Maybe Laura wants to comment any additional.
No, I think that's great. And yeah, I agree that the idea is that you can use these case report forms in any context. So we have several ISARIC members who use our case report forms in the ICU. We have a lot of ICU networks that are a part of this. We also have national networks that might be collecting hospitalized case data or even some community-based data. So the idea is that, yes, they're flexible to any different context. Now, an admission and the caveat on that, we don't want to present any of these tools and claim that they're finished or that they're ready for everything. We've started with the diseases that we have experience in. And our plan is to build on that library of diseases and the questions that inform research on those diseases gradually as you tell us which diseases it is that are important to you or which populations you want to see have specific questions about. And therefore, we hope to work with you, the clinical data patient-facing experts, to know what's the next disease that we should work on, what's the next population we should develop this for. So please do reach out. We have a process to develop our template case report forms that we'd be thrilled to work with you on.
We also have a question from Monira Sarmin, and it's about if people need to ask for approval of the participating countries if they want to use data from ISARIC from their specific analysis. So the answer is yes. Under the what we call the ISARIC partner analysis schema, that is our data governance structure, the site that captures the data remains as the owner of the data at every time. So that means that we will facilitate an inventory of data so people can request that data, know what data is available, but the actual data is only going to be shared after a statistical analysis plan is shared with the sites that owns the data and they do not opt out of that. And that after that point, we will share the data. In addition to that, when the manuscript is over and the analysis is done, we also request that that draft paper is rotated again with the owners of the data so they can give input or potentially say that they don't want their data for that particular study. That has never happened, but the mechanism is to protect the ownership of the data. In addition to that, people that collect the data or the owners of the data are intended to be listed as cited contributor in the final manuscript, and we will also plan to share a DOI for that particular data set. So those are the mechanisms that we acknowledge that people continue to own the data, but also that they are properly acknowledged for the contribution in the future of research, but also how the data can be reusable and the evidence that are more useful for several things.
Maybe I'll try and tackle Dave's question, who lives around the corner from where I grew up. So Dave has asked about a smoldering endocarditis epidemic due to IVDU, and how might ISARIC be able to support this? And this, I think, to be really honest, Dave, is a good example of where we've got great tools that aren't yet developed in all areas. And so one way that that collaboration could go forward is for you to look on Bridge, which is the application that Esteban presented, and you could start with a template or start with the full list of questions and say, what are the data that I would need to address this research question? And to develop the case report form that will drive the collection of the data that will answer your specific questions. That's not something that we are experts in by any means. And so we'd really rely on your expertise in that area to be able to say, this is the case report form that's needed to go forward. And then we would be very happy to support you to invite ISARIC members to participate in that collection. So we can communicate with people across the world to say, Dave is leading this initiative. These are the research questions. This is the case definition. This is what he's working on. Is anyone else seeing the same? Does anyone else want to collaborate? And that's exactly what Mediha and Barath and Claudia and Lubaba and Janice and many others who are on this call did for dengue. And I don't remember who started it. Maybe they did it together, but somebody said, this is what we need to do. And they worked together on developing a case report form that's hosted at and by ISARIC. Other people use our Bridge tool to generate their own database, and they host their own database. And now all of those sites, I think they're in about a dozen countries around the world, are collaborating together to produce dengue analytics. So ISARIC can play whatever role is useful for us to play in that, hopefully using these tools and supporting you to be able to get high quality data from around the world together quickly so you can get your answers. Esteban, my systems are a bit slow, so I welcome you to let me know if there's any other feedback. Sorry, I did say one from Iran.
So Ahmed has a question, and this is, can other data capture platforms other than RedCap be used? And can that data be visualized with Vertex? So not currently, we only connect with RedCap, and that's because the vast majority of our members is the tools that they use. It's also a tool that we have been using for a while, so it's the one we know. In theory, so those are projects that can be for the future. So at the moment, the answer would be that at the moment, no. That is definitely of interest. If any particular site has a different platform, definitely we can discuss if that can be done and how those are used. But at the moment, we only use RedCap.
And if I can add to that, Esteban's absolutely right. Our systems only generate the automated RedCap database build. So as you saw with Esteban, you can build a RedCap database in about, I think I've done it in 45 seconds. Esteban can do it faster. However, you can also generate a data dictionary that you could use in any database software. So in Senegal, we're running one performance evaluation of a rapid diagnostic test with Cobol Collect. Another free online tool. It's a really great tool, except it doesn't have an audit trail, but otherwise a good tool. Anyway, I can generate the data dictionary in Bridge and then just use that and cut and paste the questions really rapidly into Cobol Collect. So the difference is it's not an automated process. We haven't done everything for you, but we give you a data dictionary that uses data standards and controlled terminologies that you can then cut and paste into whatever data software system you want.
We have a question from Maria Nunez, and that is if can we get RedCap through ISARIC? So RedCap is a open source tool, so it's a software that people can have access to. However, that will require an IT team of the institution to actually manage, install, and the servers. That is where the cost of having the tool is. So I want to be careful with this. The tool is open, but will imply cost of the institution that have those. From ISARIC has a RedCap, and recently we will have a data management center that will help us further that ISARIC RedCap. We are happy to help institutions that do not have RedCap to have their own studies, and that also fit with the partner analysis schema. But it's not that we gave people access to RedCap as a tool. We can give people access to a specific data that we are conducting, and we can help with that data management aspect to some level. I don't know if that's clear.
I guess as a result of COVID, our strategy really pivoted towards supporting local data capacity. And I can tell you, sitting in Senegal, that's really important to our Ministry of Health and my colleagues. So they prefer the data to sit here. And so what ISARIC can do is to help us with instructions of how to set up RedCap, tell us where to get it, make sure we have the links. But we ourselves have accessed RedCap, done the installation. We have people and servers who are able to manage that. In the event of an outbreak, ISARIC's always there for you for a backup data hosting service. So we'd prefer you host the data. We're happy to do it if that's really useful to you and helps you respond to an outbreak quickly. Anything I'm missing on the chat, Esteban?
Not that I see. I think Irium, Florence have a similar question, but that is like, do you need to have a RedCap subscription to this? But I think that is covered by what we just discussed. But in addition to that, can you upload images, for example, lesions? Yes. For example, for mpox, we allow the possibility to have pictures of lesions, and those are uploaded in there. So from the point of view of the CRF and REDCap, yes, it's possible to do that. And we have in Bridge some functionalities that allow how you upload different, we call it photographs.
With sincere thanks to Esteban and all of you for coming, I think we'll wrap up there, because don't worry, we'll be back. So we'll send you news about future webinars with agendas, so you can see what it is that we're presenting, so you can talk to the people who have used it on the ground and see what the challenges and benefits were. And also so we can take a deep dive into the really sort of technical back end of it. That will be coming in the coming months. We'd love to hear from you. Our email address is data@isaric.org. So let us know how we can help. We're a small team, but a very hardworking and motivated one. So we'll get back to you as soon as we can. Sincere thanks to Sarah and Tom, who are on the call helping to manage this, Isabel and Asia, who put it together, and the whole ISARIC team globally. So nice to see many partners here. Really heartwarming to see a lot of familiar names in the chat. Thank you, all of you, for your time. And hopefully we'll see you again in a month, if not before then. And everyone's welcome to Dakar. Thank you so much, Esteban. Thanks, everybody.
Thank you, everybody.
Have a nice day. Bye.